So welcome everyone to our Your Child's Health University lecture tonight. I am Felice Stonestrom. I manage the community programs here at Lucille Packard Children's Hospital, Stanford. And it's my great pleasure to introduce our lecture tonight entitled Preventive Hip Care for Children and Adolescent Athletes. Dr. Stephanie Poon is the co-director of the Stanford Child and Adult Hip Preservation Center and clinical assistant professor of orthopedic surgery at Stanford University School of Medicine. She received her undergraduate degree from Stanford University and medical degree from UCSF. She graduated from the Stanford Orthopaedic Surgery Residency Program and then completed her fellowship in hip preservation surgery at Harvard Medical School and Boston Children's Hospital. So let's welcome Dr. Poon.
Thank you, Felice, and thank you for having me speak tonight. My hope is to impart some of my thoughts to you on the philosophy of hip preservation surgery and to share with you my framework for really approaching a common problem, the child and adolescent with hip pain. So the objectives for tonight are to go over hip anatomy and function, to understand the red flags for a hip at risk for mechanical damage and degeneration, and to describe treatment options for preventing hip damage in both children and adolescents. So why does this matter and why do we care? Well, children are being more athletic and active year-round than ever before, and so their risk of getting overuse injuries is just really increasing. In their athletic pursuits, children are really testing their hip range of motion limits, and those ranges of motion are not necessarily physiologic, and so their hips are really being used at their limits of function, and this can often contribute to overuse injuries as well. Adolescents in particular are especially susceptible to injuries that are unique in their age group. And so in adolescents who are undergoing large growth spurts, their limb lengths, their bones are often growing faster at a quicker rate than their muscles and tendons can keep up with. And this puts extra stress on their growth plates and other areas that are growth centers and can often result in special types of fractures that only older children or adolescents can get. So the problem for parents and for clinicians is to really find out which kids actually have a problem with their hip. Groin pain is a pretty common complaint. So how do we predict who might actually have a problem with the hip versus a problem with just the surrounding muscles? The other problem is that trauma is unpredictable. So you can't really predict that someone's going to tackle you during a football game or that maybe you're going to slip while riding your bike and fall onto your hip. But there are certain types of hip problems that we can identify at their early stages and try to prevent from worsening our children's hip function. So the question really is, how do we identify the hip at mechanical risk for degeneration? Like kids themselves, hips really have many different personalities. And developing hips are impressionable, so that there are actually positive ways to influence hip behavior through surgery. So at the Stanford Child and Adult Hip Preservation Center, which is the first comprehensive hip preservation center established on the West Coast, really dedicated to child, adolescent, and young adult hip problems with interdisciplinary collaboration between orthopedists, physiatrists, radiologists, physical therapists, and athletic trainers. Our mission is to really identify hips at mechanical risk for damage and subsequent development of arthritis, to carefully examine and thoughtfully analyze each case, and then to develop a customized treatment plan that optimizes hip mechanics, increases joint longevity, and improves the quality of life for each individual child. So before we delve into what is abnormal for the hip, we must define what is a normal hip And that's often more difficult to do than often thought, because there's not one perfectly shaped hip for every possible type of physical activity that people like to do. But in general, a happy hip is one that is both stable as well as free of impingement during motion. So you want a hip that is stable enough to tolerate all of your activities, high impact activities, but not one that's so constrained that you can't have sufficient flexibility. Misadventures into either end of this spectrum of mechanics leads to abnormal hip mechanics and results in pain. So some important definitions to go over are first some hip joint anatomy. And so the hip joint is a ball and socket joint consisting of the socket, called the acetabulum, and the ball, called the femoral head. Both are lined by this very smooth, cushiony cartilage tissue, which provides for frictionless movement within the joint. The rim of the socket is also lined by a structure called the acetabular labrum, which is a ring of fibrocartilage that really sits at the edge of the socket and acts kind of like an O-ring or a gasket around the hip to kind of hold the hip fluid inside the joint and to act kind of like a bumper or a cushion when the hip is flexed. Instability of the hip joint is the situation where there is insufficient constraint of the hip joint to tolerate an individual's activity demands. Therefore, you have a high concentration of high forces at the rim of the socket, and the acetabular labrum, this fibrocartilage ring, becomes a substitute weight-bearing structure, which it wasn't really meant to be. And so the prolonged high forces at the rim of the acetabulum usually occur over a long period of time and result in labral damage. Here's an example of acetabular dysplasia, or a very shallow hip socket, causing instability of the hip and a resultant associated labral tear that you can see on the MRI, where the labrum has actually separated from the rim of the socket. Another important definition is impingement, which describes the abnormal dynamic contact or mechanical conflict between the proximal femur, the acetabular rim, and the adjacent acetabular cartilage and the labrum. Here's an example of femoral acetabular impingement, mostly because of an out-of-round, prominent femoral head-neck junction. You can see that there's decreased offset between the femoral head and the femoral neck, and also an abnormal convexity at the femoral head-neck junction, so that when the hips are flexed, this prominent region of the femur contacts the rim of the acetabulum and causes damage to both the acetabular labrum as well as the acetabular cartilage. In addition to labral damage and cartilage damage, you can also see on the MRI that the femoral head-neck junction that is prominent there actually also sustains some wear and tear and damage. And you can see this manifested as cysts within the bone, these little collections of fluid that show up as bright white circles on the MRI. So our goal is to keep hips within this green zone of functional happiness, an equilibrium between instability and impingement. However, hip mechanical equilibrium is also subject to the modulators of activity level and time, and these factors can determine if and when a mechanically disadvantaged hip makes itself known. Hips that are outside the green zone of functional happiness, in the red zone, are unhappy and painful. These hips are at risk for mechanical failure over time. Our aim with hip preservation surgery, then, is to bring these at-risk hips in a state of poor function back into the green zone of good function so that people can participate in their activities for a longer duration of time. So when we approach older children and adolescents with hip pain, there are several questions and a typical history that is often elicited. And so when we look at the onset of symptoms, I like to determine whether the onset is insidious or acute in nature. If the pain started occurring without any sort of inciting injury or any identifiable event, then more likely this is an overuse injury or an intra-articular injury, because oftentimes for intra-articular hip pain to actually make itself known, it has to be pretty severe to the point where it's been going on for at least a few weeks to a few months. For hip pain that is more acute in nature, where the patient can tell you exactly when it happened, during a sports event, during a game, usually that indicates more of a muscle strain, a fracture, or a dislocation of the hip. The location of the pain is also very important. So pain that really manifests as groin pain or anterior hip pain is more often really truly intra-articular ball and socket joint pain. Pain that is in the back of the hip, more in the buttocks, usually suggests more of a muscular source of pain or perhaps the lower back. That's not to say that intra-articular hip pain can't also manifest as buttock pain, but more often you'll get both groin pain and buttock pain at the same time if it really is the hip bothering you. Sometimes, especially in younger children, referred pain from the hip is very common, and the pain from the hip will refer down to the knee, to the point where the child will actually just limp and complain of knee pain, not any hip pain. So if the child complains of knee pain, but the knee is rather benign looking, it's not swollen, there was never an injury, the x-rays look fine, then the hip would be your next possible area to look at for a cause of knee pain. I also ask the patient, with what activities does the pain occur? And so if there's pain with bearing weight, that suggests that there is an actual structural insufficiency of the bony structure of the hip. So situations such as stress fractures, fractures around the hip, and acetabular dysplasia, where you have abnormal high stress at the rim of the acetabulum in weight-bearing positions, those things will often cause pain when the patient is standing up or when they're walking. I also ask if they have pain in certain positions or activities. So if they have pain with activities involving hip flexion, that suggests to me that they're having more of an impingement type of scenario where they have an out-of-round femoral head that is contacting the rim of the socket when they flex their hips. If they have pain with hip extension instead, that suggests to me that maybe the socket is a little too shallow. And so when they stand up or when they extend their hip, bringing their leg backwards, the femoral head is actually escaping the front of the socket, escaping the front of the shallow socket and causing pain. I always ask if a patient has a family history of hip dysplasia or early hip arthritis, such as a relative who had a hip replacement before the age of 60, because hip problems can often run in families, and a positive family history combined with symptoms occurring in a child or adolescent really raises the flag of perhaps the child really does have an intra-articular true ball and socket joint type of hip problem. So I always see how the patient walks, and one sign of hip pathology is if they walk with this characteristic gait called an abductor lurch, where they really kind of waddle and they shift their torso towards the symptomatic hip, the side that is affected and painful. And those muscles around that hip are weakened, and that's what causes this type of waddling gait. When I test their range of motion, sometimes there's snapping or popping of the tendons around the hip. And this usually occurs because of either a tight psoas tendon, which is a hip flexor tendon, or sometimes the iliotibial band, which is a very tight band of tissue on the outside of the hip. And this can be occurring in isolation because of tight muscles and tight tendons, but sometimes it can also be due to abnormal mechanics within the hip itself, and the muscles are actually overworking to try to compensate for the abnormal mechanics and getting tight and therefore snapping and popping. I always palpate the various bony prominences and tenderness, look for tenderness at growth centers, because in adolescents and in children, these growth centers are still developing and are especially susceptible for special types of fractures, especially in situations where there has been some sort of traumatic event or something actually happened during a game. So these centers are the iliac crest, the anterior superior iliac spine, the bony part of the hip in the front, and also the greater trochanter, where you can sometimes get some inflammation of the soft tissues around that bony part of the side of the hip that can cause pain. I next move on to getting x-rays, and I always get x-rays in two orthogonal planes, so always a front view and a side view of the hips, so that we have a better three-dimensional idea of what the hip might look like. And so I always get an AP pelvis, which is a front view of both of the hips, so that I have a good overview of what the hips and the entire pelvis looks like. And if one hip is painful but the other isn't, then it's also helpful to see what the non-painful hip looks like as a comparison for this patient. I always get a side view as well. And sometimes I get some specialized views, such as the false profile view, which is an oblique view of the hip showing the front coverage of the femoral head, how much the acetabulum covers the front of the femoral head. And also a von Rosen view, which also gives me more information about the congruence of the hip, whether the femoral head really fits within the socket. After getting x-rays and examining the patient, I then think, if there really is a true intra-articular problem inside the hip joint, my next study is to get an MRI or an MR arthrogram, which is a special MRI where a little bit of contrast dye is injected into the hip joint so that the soft tissue structures are better visualized. So you can see the cartilage, the tendons, and other soft tissue structures like the acetabular labrum a lot better on an MRI, and you can see if there's any damage to these structures. So when I look at the etiologies or causes of childhood and adolescent hip or groin pain, I think of these causes as two different groups. One is unpreventable. These are traumatic injuries, and as much as we want to prevent the traumatic injuries, sometimes we can't prevent them from happening. And these are fractures, dislocations, things that occur because of some sort of impact. The other class is preventable hip pain, which is caused usually by mechanical instability of the joint, most commonly by acetabular dysplasia, and the other is mechanical impingement of the hip, most commonly caused by femoral acetabular impingement. So I'd like to focus on the preventable causes of hip pain in this population. So the first scenario I'd like to discuss is instability of the hip, and in particular, we'll look at acetabular dysplasia. The typical patient is a young female, perhaps a dancer, a gymnast, a figure skater, or a cheerleader, sometimes a runner or other type of athlete. Usually they're quite active and usually participating in sports that require a lot of flexibility of their hips. Sometimes there is a past history of developmental dysplasia of the hip or a breech presentation at delivery. And oftentimes there is a family history of hip dysplasia or osteoarthritis or a hip replacement occurring at a younger age. The pain is usually insidious in onset, so just gradually occurring over time. But it is activity related, so the pain is worse with weight bearing, with walking, anything that causes more forces to be concentrated at the rim of the shallow socket. And these patients will often complain of anterior groin pain, sometimes lateral pain as well, but almost always groin pain. If they have labral tears or cartilage damage, sometimes they will complain of mechanical symptoms as well, such as a subjective feeling of instability of the hip, like their hip wants to kind of pop out of the socket, or they don't really trust their hip. They feel like it's going to give out on them when they step on that leg, or they might feel some catching symptoms when they move their hip. On physical examination, I test their hip flexion and their internal and external rotation of their hip. And oftentimes, they don't lack motion at all. They're actually hypermobile because with a shallow socket, you don't have much constraint of your hip joint at all. And so you often have very flexible patients, but they will have pain with hip flexion. They often have an anterior impingement test that is positive. And an anterior impingement test is this first picture where you flex the hip up to 90 degrees, internally rotate the hip, and adduct the hip, meaning bringing the leg towards the midline of the body. And that maneuver basically pinches the labrum, the irritated labrum in hip dysplasia, against the rim of the socket and against the femoral neck. And when you put the hip in this position, the labrum gets pinched and the patient experiences pain. They often have also a positive anterior apprehension test, which is where in the bottom picture you have the patient actually extend their hip off the side or the end of the table so that the hip is extended and then the hip is then externally rotated. And this puts the hip in a position where the femoral head wants to escape out of the front of the socket. And when you have a shallow socket, that also creates discomfort and pain referred to the front of the hip, to the groin. The patient will often limp and often has a positive Trendelenburg test, which is where you have the patient stand on one leg and they have trouble doing so because of weak hip abductor muscles. The x-rays that I get show a very shallow hip socket, and so there are several measurements that we use. The first is the lateral center edge angle, looking at how far over the side of the femoral head does the acetabulum cover. A normal angle is greater than 25 degrees, and this angle is measured from the center of the femoral head and is subtended between two lines between the center of the femoral head vertically and another line going from the center of the femoral head to the edge of the socket. In dysplasia, you have a lateral center edge angle less than 20 degrees. You also look at the tonus angle, which is a measure of the obliquity of the weight-bearing roof of the acetabulum. It really gives you an idea of how steeply sloped the roof is, what the acetabular inclination is. And if you can imagine, the more steep this roof is, the more likely your femoral head wants to slide out of the socket. If you have a flatter roof, one where the tonus angle is less than 10 degrees, then you have a less likelihood of having this sort of sliding or shear types of forces between the femoral head and the socket. Another measurement that we use is Shenton's line, which is an arc drawn between this part of the pelvis along the top part of the obturator foramen. And if you drew an arc towards the bottom of the femoral neck, usually that arc would be continuous. If you look at the hip if you look at the left hip over on the right side, you can see that Shenton's line is disrupted. This arc is not continuous because the severity of the hip dysplasia is such that the femoral head is actually trying to escape out of the socket laterally. So that is a subluxated hip and at high risk for degeneration of the cartilage and development of early osteoarthritis of the hip. The false profile view gives me a good idea of how well the acetabulum covers the front of the femoral head. And you can see in dysplasia, usually a normal hip has an anterior center edge angle of greater than 25 degrees, but in dysplasia, you have an angle that is less than 20 degrees. On MRI, acetabular dysplasia often shows a labral tear, and the labrum often looks hypertrophic or overgrown because as this hip has developed over time, the labrum has tried to compensate for a deficient bony structure. And so since the bony acetabulum is shallow, the labrum has tried to overgrow and become a substitute part of the or substitute extension of the side of the socket to give more support to the femoral head. You can often see cartilage thinning and sometimes even a fracture at the rim of the acetabulum if the dysplasia has been ongoing for a very long time. So the treatment for acetabular dysplasia is a periacetabular osteotomy, or a PAO. And the goal of the PAO is to reorient the weight-bearing surface of the acetabulum into a more horizontal, stable position. In this way, we can distribute the weight-bearing load between the femoral head and the socket over a larger surface area and turn those shear forces that you see in the very sloped upwards acetabulum into a more compressive type of force. So here's an example of one of my patients, a 15-year-old boy who had bilateral anterior hip pain or groin pain for 5 years, the right one a little bit worse than the left. He walked with a limp on both sides because both hips were hurting. And his hip really was worse with weight-bearing activities such as walking. On physical exam, he really had all of the similar typical physical exam signs for acetabular dysplasia with a positive anterior impingement test as well as a positive anterior apprehension test. These were his x-rays preoperatively, and you can see the very shallow dish-shaped acetabula bilaterally. And so you can see that the lateral center edge angle of the right hip was less than 0, actually minus 20. The tonus angle was very steep. Usually it's less than 10 degrees, and his was 33. And the anterior center edge angle on the false profile view showed that it was actually very deficient. The front of the acetabulum did not cover the front of the femoral head at all. Excuse me. So he underwent a periacetabular osteotomy on the right side, and you can see that the right hip looks very different from the left hip at this point. If we compare the preoperative and postoperative x-rays, you can see that the lateral center edge angle really improved from a negative angle to a positive 28 degrees. The tonus angle improved from a very sloped upwards 33 degrees to just 7 degrees, so much more flat and horizontal and stable. Shenton's line, which is that line that shows subluxation of the hip, has also been restored. By 6 months post-op, his right side had completely healed and was completely asymptomatic and pain-free, to the point where his left hip was the really limiting factor in his activities. So 6 months after his first side, we went back and did his left side. So this was right after he had both done. I actually took out the screws on the other side during the same surgery. Here's another example of less severe dysplasia. So this is another patient of mine, a 15-year-old female dancer who had 2 years of worsening left groin pain. And she had a more milder type of acetabular dysplasia, but still you could see that the top of the edge of the socket really didn't cover the top of her femoral head very well. So she also had a periacetabular osteotomy performed, and at 3 months post-op, she was already back to dancing, pain-free, and at 8 months post-op, we took out her screws. So the expected outcomes and return to function after a PAO are actually a lot easier than what patients often think. They're usually on crutches with just limited weight bearing on the operative side for 6 to 8 weeks until there's some bony healing. And usually by 8 weeks, I can get them off of crutches. By about 3 to 4 months, they're usually fully healed from their surgery. And by 6 to 9 months, they can go back to sports and higher impact types of activities. At 6 to 12 months, that's when I can possibly remove their screws. The benefit of having a periacetabular osteotomy and not having a hip replacement is that you do not have any range of motion restrictions after your surgery has completely healed. There are no activity restrictions either because it's really your native hip joint is really your native femoral head and native socket that we've simply repositioned into a mechanically better position. Oftentimes, my patients with dysplasia are young women, and so they have concerns about whether they can become pregnant later on in life and whether or not they can deliver normally. And those things are not affected with the PAO because the pelvic ring dimensions are really unchanged with this type of surgery. The outcomes are quite good. At 2-year follow-up after PAO, the clinical improvement is evident in both activity level and pain scores in patients. And at 10 years post-op, almost 90% of patients are free of needing a total hip arthroplasty for end-stage osteoarthritis. At 20 years, almost 60% are free of needing a total hip replacement. So moving on to the other end of the spectrum, we will now discuss situations that cause impingement of the hip. So femoral acetabular impingement is usually thought of either as being femur-based, which is what we call cam impingement. Those are cams and pistons in an engine, and that's how the asphericity of the femoral head got its name. And it can also be acetabulum-based, which is what we call pincer impingement, where you have overcoverage of the femoral head by a deep socket, or a socket that is turned backwards abnormally. Most often we see a combination between both cam and pincer morphologies. The basis for the theory of impingement-based arthrosis is that chronic impingement during hip motion causes mechanical damage to the acetabular rim and the adjacent cartilage. It's important to remember that FAI is a dynamic disease, a conflict in motion between the femur and the acetabulum, usually in positions of hip flexion. So what happens with cam FAI is that this abnormal prominence at the femoral head-neck junction, as the hip is flexed, actually enters the socket and causes impingement or mechanical conflict at the rim of the socket. And over time, this actually scrapes the acetabular cartilage to the point where the cartilage delaminates or separates from the rim, the edge of the socket, and that's how you get cartilage problems and development of arthritis later on. In the case of cam FAI, the pattern of injury involving cartilage shearing and delamination by the cam deformity is often much more severe than expected on preoperative imaging. With Pincer FAI, you have overcoverage of the femoral head by a deep socket or retroversion of the socket, and in this type of FAI, you actually have pinching of a prominent rim against the neck of the femur, which then crushes the labrum and causes basically instability of the hip in the other direction. The red flags for femoral acetabular impingement are that usually the patient complains of pain in positions of hip flexion. So they can be either male or female. But more often, in my practice, male, they often have a family history of osteoarthritis at an earlier age, and oftentimes their symptoms are insidious in onset. They often complain of groin pain as well, and they describe themselves as not being flexible. They feel like their hips are stiff or tight, and they describe themselves as being people who are just not flexible. They've never been flexible. They sometimes complain of mechanical symptoms such as catching or locking, especially if they have any cartilage damage or labral damage. On physical examination, they often have limited range of motion. So in contrast to people who have hip dysplasia, people who have impingement have limited flexion, usually just to 90 degrees or less than that. And they also have limited internal rotation of the hip. They'll have much more external rotation than internal rotation. They'll often have a positive anterior impingement test because, again, the acetabular labrum is getting pinched and squished when you put their hip into that flex, internally rotated and adducted position. Sometimes they'll actually have pain with simply hip flexion. So again, on radiographs, what you see is this out of round femoral head that is contacting the acetabular rim in positions of hip flexion. Sometimes you'll see a very deep socket as well. Now a word about labral tears, because sometimes you work up hip pain, you get the x-rays, and you get an MRI, and the MRI shows a labral tear. Now, a labral tear can occur in both acetabular dysplasia and FAI. And the labral tear usually doesn't occur just by itself. Usually there's a secondary underlying structural bony problem that is the primary problem with the hip that then results in the labral tear because the labrum is often the initial area of damage whenever there's something wrong mechanically with the hip. So, in order to tell the difference between dysplasia and FAI, first you note that there are similarities. Both can present with groin pain or anterior hip pain, and both can have pain with hip flexion, as well as limp and have weak hip abductor muscles. And the anterior impingement test is positive in both. The difference is that in dysplasia with your shallow socket, you often have hypermobility of the hip. And so these patients have preserved range of motion. And they'll also have a positive anterior apprehension test, remember, with the hip in extension and external rotation. In FAI, patients will often have decreased hip flexion and internal rotation. So the rationale that we have for impingement-relieving surgery is that for FAI, we want to alleviate the mechanical conflict that then causes intra-articular damage. And so this is a mechanically based treatment goal. We try to improve joint clearance by recontouring the femoral head neck region and recontouring the acetabular rim so that there's more space for the hip to flex so that patients can participate in their daily activities and sports without hip pain. So for pincer impingement, where you have a prominent acetabulum, what you can do is trim the rim of the acetabulum and repair the labrum. For CAM FAI, what you do is basically recontour the femoral head-neck junction and cut out that prominence that is causing the scraping of the cartilage inside the socket. Usually, we approach FAI through an arthroscopic approach, and this is because usually most types of FAI can be managed through a minimally invasive hip arthroscopy. So you can see in this patient, in the image before undergoing the osteochondroplasty or shaving down of the femoral head-neck junction, there was this part that was a little bit more aspherical. And in the next picture, after the femoral osteochondroplasty, you can see that there's more of a concave appearance to this area of the femur. So now when the hip is flexed up, there's more room for the hip to move before the neck of the femur contacts the rim of the acetabulum. These are arthroscopic pictures of the hip undergoing FAI surgery. So on the top series of images, you can see the flap of cartilage and the unstable labrum, which is the region of where the damage was occurring. And what we did was trim away the damaged cartilage and refixated the labrum to the rim of the acetabulum. In the bottom pictures, you can see the cam deformity, this sort of whitish area where you can see that there's an abnormal convexity, this abnormal bump in this region. And using a burr, we shaved down this region so that this convex area became concave. Here's a case example of one of my patients. He's an 18-year-old male collegiate baseball pitcher who had 3 to 4 years of worsening right hip pain, really worsened positions of flexion or rotation of his hip. And you can see on his x-rays that he has a big cam deformity, this area that is aspherical and in positions of hip flexion contacting the acetabular rim. And so you can actually see on the MRI that there are areas in the labrum where there's damage and also areas in the acetabulum that are beginning to degenerate. So intraoperatively, you can see that there really was this large labral chondral separation where the labrum was detaching from the rim of the acetabulum, and you can see that there's a cartilage flap where that cartilage is delaminating and separating from the underlying bony acetabulum. So what we did was a repair of the labrum as well as resection of the cartilage flap and a microfracture, which is poking holes into the underlying acetabular bone to try to elicit some bleeding and bringing some stem cells into that region to grow some fibrocartilage soft tissue in that region. And here's the cam deformity, this abnormal bump on the femoral head-neck junction. And this is after we performed our osteochondroplasty, shaving down that region to restore a more normal contour to this femur. For bigger types of FAI deformities where an arthroscopic approach may not be feasible, you can also perform a surgical dislocation of the hip where you actually take the femoral head out of the socket through a larger incision and actually trim the rim of the acetabulum and repair the labrum, as well as resect the abnormal cam deformity. And so the advantage of this approach is that if you have a very large deformity, this approach gives you a 360-degree view of the entire femoral head and really allows you to see what you're dealing with. So one special condition that can cause FAI later on in life, a condition that only really occurs in older children and adolescents, is a slipped capital femoral epiphysis, or a SCFE. And the reason why I talk about SCFEs is because it occurs in adolescents and older children, but even after treatment of SCFEs, it can often cause impingement because of the residual deformity that you get because of the SCFE. So the history of these types of patients is usually the child will complain of knee or thigh pain for several weeks before being evaluated. There may or may not have been some sort of inciting injury, but usually it's a slow onset of symptoms. And sometimes their parents will start noticing that they have been walking with their foot externally rotated or their toes turned out on that side. When they flex up their hip, they can't flex their hip without externally rotating their leg too. And they often have pain with weight bearing. On imaging, what you can see is there can be widening of the growth plate and relative loss of height of the epiphysis or the femoral head. You can also see that when you draw a line along the lateral aspect of the femoral neck, you can see that the top of the femoral head really doesn't touch this line like it should. And on the frog lateral view of the hip, you can really see how the epiphysis, or the femoral head, has really displaced posteriorly. And essentially, this is a fracture through the growth plate of the proximal femur, allowing the femoral head to slip backwards into the socket and the femoral neck to become very prominent anteriorly. And so this is a major problem because, one, this can cause a problem to the femoral head blood supply, and you can get something called avascular necrosis, where the femoral head actually dies and you get severe arthritis very early. The other problem is that if the hip heals in this position, as you can imagine, there would be very little hip function available for the patient because any sort of hip flexion would cause that corner of the front of the femoral neck to hit the front of the socket and prevent any further hip flexion. So SCFE can be associated with some endocrine abnormalities, which are more common in children who are less than 10 years old or who are rather skinny and who have thyroid problems, vitamin D deficiency, and growth hormone disturbances. And so in those patients who have these risk factors, we'll often do some blood tests to test for endocrine abnormalities. The treatment depends on the severity of the slip. So for mild SCFEs, where the epiphysis is not so displaced, in situ pinning, where 1 or 2 screws are used to just hold the femoral head in its new position, is the preferred treatment. In more severe slips, an open reduction, meaning actually exposing the hip joint and then carefully realigning the top of the femoral head onto the femoral neck, might be a better procedure. It's a little riskier, but can restore more normal anatomy to the hip and provide better function. The goal of any type of surgery for SCFE is to, one, close the growth plate so it no longer continues to slip. But often treatment of any kind results in a CAM type of deformity and FAI later on in life, and usually leads to arthritis of the hip. And as we mentioned earlier, a severe slip can also result in AVN of the hip. So here's an example of another one of my patients, an 11-year-old girl with an 8-month history of worsening bilateral thigh pain and progressively out-toeing gait. And so on these x-rays, you can see that, especially on the x-ray on the right side, that her femoral heads look like they've slipped backwards into the sockets more so than the femoral necks. And so what she had were in situ pinning of bilateral SCFEs because her slips were mild and they were chronic. And so for her, in situ pinning offered the best type of treatment that was least invasive with least risk. However, in another one of my patients, a 13-year-old girl with 4 months of right knee pain after falling down while playing basketball, she was limping and unable to bear weight without knee pain. And finally, someone got x-rays of her hip showing this very severe SCFE. And you can see that in situ pinning of this type of hip would not allow her to flex her hip at all, really. So for her, what we did was a modified Dunn osteotomy through a surgical dislocation approach, where we actually dislocated the hip, took the femoral head out of the socket, very carefully realigned the top of the femoral head to the femoral neck, and put screws in there to hold it in place for it to heal in a more anatomic position. So this is what her hip looked like 3 months after surgery. And you can see that the hip now looks a lot more anatomic. And this type of hip will allow her to have much more normal hip function and even be able to play sports later on. So the treatment goals for a SCFE are, one, to identify SCFEs early, because unfortunately too many SCFEs are actually identified late, as SCFEs often present as knee pain. And the second goal is to prevent the development of avascular necrosis, FAI, and hip arthritis. So you can see if we were to pin that first hip in that position, that would be very poor hip function over time. But with certain types of surgeries that we now have in terms of techniques, we can restore normal anatomy and try to prevent hip arthritis and preserve hip function in these patients. So in summary, the preventable causes of hip pain include acetabular dysplasia, which causes mechanical instability of the hip. And these patients often have preserved range of motion of the hip, but they have pain with standing and walking, weight-bearing activities. The other causes are mechanical impingement caused by femoral acetabular impingement, these patients having limited range of motion, and often pain with hip flexion, such as squatting and sitting positions, as well as slipped capital femoral epiphyses, which are conditions affecting adolescents and older children, and manifest as an externally rotated leg with limited flexion and internal rotation of the hip, and often presents as knee pain. And SCFEs can often end up being femoral acetabular impingement a few years later after treatment. So the conclusions that I have to leave you with are that happy hips really live in between instability and impingement, and that subtle anatomic variations can predispose people to developing hip degeneration. The red flags to look out for parents and for clinicians are any sort of groin pain in a child, because groin pain is not normal. Knee pain in a child can be referred pain from the hip, so always be suspicious of knee pain, especially if your knee examination and x-rays and MRI are all negative. Sometimes periarticular hip pain, such as pain in the muscles around the hip, can actually be signs of mechanical problems within the hip joint, causing compensatory muscular pain. So if the muscular pain does not go away with physical therapy or other conservative measures, then I would take a closer look at the hip joint itself. Labral tears are usually not occurring in isolation. So if you see a labral tear on a radiology report of an MRI, then I would look more closely to see what is the underlying bony abnormality causing the labral tear. And always, if there's a family history of hip dysplasia or early hip osteoarthritis, have a high suspicion that there may be either FAI or hip dysplasia occurring in the adolescent that is starting to become symptomatic, especially in an active population. So thank you for your attention and for your time, and if there are any questions, let me know. Thank you.